from lovely Pueblo, Colorado today. Thank you to everyone who's attending in person, and thank you to everyone who's online. We're here tonight to talk about MS with Dr. Enrique Alvarez. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen and Genentech. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options. We also have most of our programs are recorded on our YouTube channel. Our next big event is our Spring Education Summit. It's coming up on April 26th. You can come to that in person at Anschutz in Aurora or stream it online on Zoom. The topics that we'll be covering include research updates, brain volume changes, evaluating risk and benefits with medications, and MS progression. We announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite as well. And all of our education programs are free of charge to anyone interested. And now I will introduce Dr. Enrique Alvarez. Dr. Alvarez is our medical director at the Rocky Mountain MS Center. He's a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at the University of Colorado in 2013 and is now the director as well as the vice chair for clinical research. We did have a lot of great questions submitted tonight, so I have grouped some of them together if they were similar questions. We'll get to as many as we can, but just a reminder that today's presentation is for informational purposes only, and all decisions regarding MS treatment and medications should be discussed with your neurologist. With that, I'll turn it over to Dr. Alvarez.
Something else. This is your time to ask questions, so feel free to do that, and there'll be some questions through the chat as well, that kind of stuff. So any burning questions from the audience?
We'll all start.
Awesome, good. I like non-shy people. That's awesome.
Hi, I'm Barb Lytle, and I'm actually one of your patients.
Awesome.
And he's awesome. Anybody however, I haven't getting to see him. So the PIRA issue, PIRA. Okay. Would you want to enlighten us and I want to say make it a little bit more understandable for a non-medical person?
Okay.
Thank you.
So PIRA, basically we're talking about progression independent of relapse activity. I mean, this is such a broad question. So this one I am going to go on many tangents because I think the question helps explain the confusion that we have in our field. Okay. And so I think if you think about our disease as like almost two diseases, it starts to make a little bit more sense, at least to me. Traditionally, we've kind of talked about four different types of MS, you know, relapse and remitting, primary progressive, secondary progressive, and progressive relapsing is, you know, kind of got originally defined. The problem is that's only clinical activity, right? So that's kind of like when you see somebody coming in without MRIs or anything else to add to that story, you come in, you tell me, hey, I'm getting worse. What do I make out of that? So we talk about getting worse over hours and days, and that's a relapse. If it gets better, hopefully it's remitting. So relapse and remitting kind of comes in through that. Not everything that relapses remits. So we're kind of dropping the remitting part and just talking about relapsing kind of disease. And then progression is a little bit, it's really meant to be this slow, gradual decline in function. And how slow? Really should be fairly slow. Pure progression should be the kind of thing that if you, I mean, slow is relative, but if you think about a patient with Alzheimer's disease, Parkinson's disease, if you know people with those conditions, you're talking about changes that happen almost year to year. That week to week, you're not seeing a difference, month to month, not really. maybe at 6 months you're seeing sort of a change. But you're thinking about this very slow decline. There's a lot of stuff that happens in the middle. We worry about that stuff too, because our MS patients can develop other things. You know, is it a tumor? Is it a slipped disc? Is it, you know, a broken bone of something that maybe happened? You know, for us, one of the big things that we used to talk a lot more that maybe we don't talk about as much now is PML, this brain infection that can kind of happen. That changes over weeks to months. But if we see that, we need to be thinking about it. The problem a little bit is we've never distinguished that rate that much because we can progression sometimes if you're having relapses that kind of stack on each other. So instead of having an attack and then things getting better, but you're having an attack and then another attack and then another attack, you know, things can seem like they're progressing really fast. They've never had a chance to remit or get better. And so in the old days, you know, we would see 20-year-olds and call them primary progressive MS. And the problem is they were just stacking all their attacks, and it was one after the other, and just had a ton of disease activity. So we're now relying on MRI a lot to be able to kind of say, hey, I'm not worried about relapses, just try and separate those events that much. And with our drugs, we can stop those relapses pretty much. I mean, 99+% of our patients, you know, don't have new activity on MRIs. So when you come in and you say, why am I getting worse, but my MRI, you know, is stable, the idea is that that's progression. You know, it should be kind of this slow, gradual decline, or maybe there's something else going on, you know, a patient with diabetes or other things like this that are kind of contributing to that. We try and talk about then things getting worse because of worsening, which is like a bigger umbrella term, or we talk about progression, which is supposed to be more specific to MS. How do we separate that? We guess. We try and do MRIs. We try and say, hey, you know, if we do an MRI of your spine, we can see there's not a slipped disc. We can check your sugar levels and make sure it's not diabetes. You know, so you know there's certain things we can kind of eliminate out if we're worried about them. But sometimes we're kind of not sure. Okay. On the relapse side, then we have to worry about also pseudo relapses. So these are real symptoms, but they're not associated with MRI changes. So what does that mean? That means your body isn't working quite as well. If you kind of take it at a little bit more basic level, we all have these, right? You have a night where you don't sleep very well. How's your memory the next day? Not very good. If you exercise a lot, do something around the house, in the yard, you know, for a couple of days straight, you know, the next day you're probably going to feel beat up, not have the same energy level, not maybe have the same strength or capacity to do things. You know, you get some rest and things get better. If you have a cold or a flu, I don't have the same energy level as if when I'm feeling well. In MS patients, that tends to affect you even more. And so heat, infections, being tired, stressed, not sleeping, I say sometimes like a full moon because half the time we don't know what that is. But those things can make MS worse. In stroke, we call it a stroke recrudescence. In MS, we call them a pseudo relapse. It's just these recurrence of things that can kind of come up. So in these short events on relapses, right, these are things that happen fast. Sometimes they're driven by inflammation, and sometimes they're not necessarily driven by inflammation. Okay, so we try to kind of say if there's MRI changes associated with it and we're seeing these events, we're much more worried about a relapse than a pseudo relapse. In progression, the way then we try to separate these things out is if you're graduating, you know, worse, the disability is accumulating slowly, you know, we worry about this being sort of more progression. If this is going like this, what we're worried about is you're having a relapse on top of a relapse on top of a relapse on top of a relapse. So I'm a visual person, so that's why I like to kind of think about it this way. So the problems a little bit with this is because you have good days and bad days, it never looks this way. It really looks kind of like this. And how much of those curves do you need to separate it out makes it difficult. So for a clinical trial, there's definitions of a relapse. Symptoms must be there for 24 hours. It has to be outside of an infection. It has to, usually be a symptom typical of MS. In a study, it has to cause enough of a change in these scales that we do to kind of be a meaningful change on that scale. And so on our disability scale, you hit a point, like a change, things get worse. And then that's a relapse if you meet all those criteria. Again, whether there's MRI changes or not makes it a little bit difficult. So whether these short events are real inflammation or not can be a challenge. For progression, to try and separate out these events without relapse, then we get to the concept of PIRA. So that was a long-winded answer to get at this concept of progression independent of relapses. So we try to eliminate these bumps, and we try to say there has to be a change in that EDSS at a visit, and then at the next visit, it has to stay up. Because in a relapse, the idea is you would kind of remit and get better and change like that. And so this is the way we measure it in a trial. But all it's trying to say when you talk about PIRA, to answer your question, is progression. Because the problem is sometimes to meet that change, it may take 10 years before you hit that threshold to have a change that on our scales we might call out. So when you look at changes for confirmed disability progression, the term that we would use in trials, the numbers might be 3%, 5% of the population in a trial that might meet those endpoints. And so this is, when we talk about PIRA, it was just in the way of a trial to kind of say, this is how we define progression.
Okay.
Is that?
So if there are people here. Oh, thank you. Forgot my old friend. If there are some of us here who are pretty stable in our MS journey, but at this point in our stability, if you will, the thinking isn't always as clear as it used to be. A lot of the other symptoms have subsided, but the cognition, there definite cognitive business going on. I call it irritating. I call it
word finding issues. Yes.
What you said. Yeah, I find it like chaos in the brain, but no, there's no voices or anything. Don't worry. But so I guess when I was doing in one of our magazines that we get with, for MS, a description of the PIRA concept, which was new to me. I realize it's been around a while now, but I wasn't familiar with it. So I guess I'm asking, does that fit the category of a PIRA situation where things are kind of simmering, if you will, in the brain? I don't like their smoldering word, but they described it as kind of a smoldering symptomatology really below the surface, which, that would describe it too. But I'm just curious because I haven't been able to get in.
So yes, progression can affect anything. It could be bladder function, it could be vision. Our core for that disability scale basically includes like cranial nerves, so it could be like double vision issues. It could be vision, so just worsening vision. We don't tend to see progression affecting that much, but it could. It could be weakness is probably the most common thing. So we tend to think about MS predominantly being legs, one or the other. It might be one side, both legs, other side, or something like this. It could be sensation, so it could be increasing numbness. But memory is one of those things that unfortunately we just don't measure well. We don't measure it well. You measure it well, right? So in our scales, right, this is like where I would say like it's part of progression. Maybe PIRA won't pick it up because for PIRA, my concerns for cognitive stuff, we were just having a discussion last night at a program with one of the docs at UT Southwestern. And it's in our scales, if you're normal, it's a 0. If you, 1 is usually symptoms, but no signs, which is a fancy way to say like you're not aware of any concerns, but somebody else is picking it up. I don't know how you have cognitive concerns that other people are picking up that you're not aware of, right? I think that's kind of where you're the happily demented stage, where you have so many concerns, but at that point you're like, whatever, you know? So I wouldn't say that that's sort of a 1. A 2 is basically you notice concerns. And to get to a 3, then it's almost like you're not aware of where you're at, what day it is, you know, and who you are. Like, that is severe cognition. That gets you to a 3. But if you need a cane to walk 100 meters, that gets you to a 6, right? So you can be really demented, and in our scale, it doesn't count as much as walking issues. And it's just the way the scales got set up. I would say now we don't agree with them, but when they were originally set up, that's kind of how they got weighed. And it's a little bit more because of the concerns around being able to measure things well. And as we get better at measuring things, I think that that would be part of it. One of the things that we can do sometimes with cognitive stuff is neuropsych testing, which can be a process of usually about 4 hours, 3 to 4 hours. And they put you through a battery of testing. And part of that testing is to see sort of what domains of memory, recognizing that memory can be many different things. So is it, you know, remembering words, remembering faces, colors, things like this. It could be executive planning, like I got to do these 5 things. How am I going to do them? It could be processing speed. I got to, you know, I'm going to think about how to do this, but how fast can I do it? And in MS, we've always said it's a little bit more of a processing speed disease than maybe a executive function disease, which we tend to think about more like with Alzheimer's, because we got to worry about that too. Usually we see more disability as you get older. So, you know, do we need to worry about those things? In the past, we didn't worry about it much because we couldn't do much about Alzheimer's. So it was like, all right, we can't do anything about progression for MS. We can't do much about Alzheimer's. So we recognize it and we say, yep, you're getting worse as far as memory goes. Sorry. You can still live independently. We want to make sure that, you know, we could kind of, you know, help out with a few other things. But the reality is there wasn't much to do. Well, we're starting to get treatments for Alzheimer's. We are starting to kind of maybe start getting some stuff for progressive disease in MS. And so trying to differentiate these things now starts to matter more. And we're getting a little bit better at it. So our conversation yesterday was a little bit about the first sign of this is probably word finding, but we don't measure that often in clinic because our tests don't measure that because we've always been so focused on processing speed. And we didn't measure executive function very much because, again, that tends to be so far out that those people aren't getting tested because we already know they have problems. And so we're starting to kind of recognize sort of a little bit, I think, along the spectrum, kind of where the memory problems are. So does that help a little bit? No. What I will lead into a little bit was I was talking about progressive and sort of some changes that are happening. And as of today and a couple weeks ago, there's a few updates that I can provide on some changes of drugs. So there was a few trials that are breaking. We heard, you know, when we talk about these 2 different types of forms of MS, the therapies that we have around sort of have mostly been for relapsing disease. The one medicine approved for treating progressive disease has been Ocrevus. We use a lot of the B-cell depleting therapies, assuming they probably work the same way on progressive patients. They do really well on relapses. They do a little bit on progressive disease. So if somebody has progressive disease, we could put them on those drugs. We can, you know, take care of this and take, you know, kind of flatten it out and say, no, really no disease. And, you know, we might bend this curve and maybe it goes a little bit like this. There's a drug, one of the new groups of drugs, the BTK inhibitors. that the first drug in that class did not work, called ibrutinib, didn't show any effect. Tolebrutinib, we heard the results last fall. We just heard, I think last week, that it might get approved by the end of September, that it was accepted, the application in full by the FDA, with the decision date by September. If we still have an FDA at that point, we're not sure. But as it stands right now, that's the plan, at least, to kind of see if that's going to get approved and somebody's still left with lights on to evaluate the application and actually process it through. The interesting piece around that drug is that its effect on this part is not very good. So we're starting to get into a situation where we start to think of, you have an older patient where maybe we don't worry about relapses much because relapses tend to die out as we get older, and you have primarily just progressive disease. That drug might by itself be okay. But I have concerns a little bit about, a 40-year-old, 30-year-old patient who's progressing, to put them on that drug and not have them on something for relapses as well, because this effect is just not going to be very good. And right now, the way we think about MS is one disease. I'm not sure insurance is going to cover that, so I'm really nervous about this. And I think it's going to be sort of what's going to happen at that point. How do we get two drugs if we need it? How are the two drugs going to interact? That kind of stuff. Part of it on this drug is, I don't want to say, hey, this is like a much better drug. It looks like it might be a little bit better than B-cell depleting therapies. Again, we don't know who's going to benefit from that drug. We've not gotten a lot of breakdown. Is it the older patients or the younger patients? We know with B-cell depleting therapies for progressive disease, it tends to work better in younger patients than in older patients. It tends to work better on men than women because they tend to have a little bit more progression than women do. So you can see a little bit more effect in them, those kinds of things. The one thing that we know so far, and the only breakdown that we've received, is that the drug might work better in people who have PRLs. So paramagnetic rim lesions. This is something we've not even really looked at in MRIs yet. It's like a new thing that we've known about for a few years, maybe associated with progressive disease. And basically what we see in the past is, if you have a lesion, some lesions will have a type of cell called macrophages. These are cells that are kind of like scavenger cells that kind of pick up debris and kind of clean up stuff. Sometimes because of inflammation, some of that includes iron, so like red blood cells and things like this. So if you got a lot of blood into those products, those macrophages will tend to kind of concentrate on the edge of the lesion. And then if you do a sequence that picks up blood, put the two images together, you'll see on one sequence the lesion. On the blood sequence, you'll see this iron ring that's kind of sitting around it. So that's the paramagnetic, because it's heavy metal, you can pick up on magnet sort of the signal for that. So you'll hear this term, I think increasingly so, about PRLs. We don't pick them up very well. Our standard MRI sequences don't do that. But the more PRLs you have, the more it seems like people responded to this drug. So what are the chances you have them? Great question. In this trial, it was about 2/3 of people tended to have a PRL or had at least one or more, with half of that maybe having 4 or more of these PRLs. So it might give us a clue as to like who might benefit, who may not, once we get the MRI sequences that can do that stuff. We have the sequences, it's just developing the protocols and all that stuff to kind of be able to do that. So we got 6 months of homework before we, can probably start doing that well. It's got some liver issues. So one patient did die from liver issues. It's probably going to require, it tends to be concentrated in the first 3 months of starting drug, but it's probably going to be weekly labs for the first 3 months. So for monitoring purposes. So again, probably not for everybody. It's going to involve, I think, a lot of discussions around this stuff and things like this. The third drug called fenebrutinib, we might hear about later this fall, is the expectation. The fourth one is still enrolling, and we might hear about it in another year and a half or two or something like this. So there's several of these drugs. We will understand maybe if some of them have less liver issues than others. Some might be better than others. Clearly, tolebrutinib seems to have a much better effect than evobrutinib, even though they're in the same class. But these are dirtier drugs than what we're traditionally used to using in MS. There's a lot of tyrosine kinases, and Bruton's tyrosine kinase is not the only one that these drugs tend to bind to. The newer ones are cleaner, so they hit fewer, but some of the older ones, and this class of drugs has been used in cancer, some of those will hit like 30 and 40 different tyrosine kinases. So they're more prone to have side effects and things like that. So that's the part that's getting better with more research and technology to understand these things a little bit better. The other thing we learned about just this morning, or in my case, 30 minutes ago, was there was a trial with Ocrevus to look at higher doses versus regular doses. In the primary trial, the measure of PIRA was much better in patients that were small. Small in kilos, you could look at it in BMI, it kind of matched up pretty well. But because it's a one dose fits all drugs so far, in small people, they got more drug per body weight than somebody who was bigger. So we could see that in bigger people, B cells come back faster and things like this. And in those small people, it drove sort of a better, less disability accumulation. So they said, well, maybe let's increase the dose and see if there was an effect with that. There's a concern with that. Originally in the trials, they did higher doses. They looked at in rheumatoid arthritis. They stopped those trials because they had more infections in patients from Asia. They tend to be smaller, so maybe got more drug per kilo and led to more issues with it. But at least from a relapse perspective, they halted the trials and development of the drug because they did not see that there was a difference in disability accumulation in relapsing patients. There's still a progressive trial, and I think that should be coming out soon, or if it has come out, I haven't seen it yet, but like, things keep coming kind of fast and furious. So we're learning a little bit about how to use these drugs better that we currently have. There's new drugs potentially coming out. We might have to learn about how to use them in combination, which we're very new to in neurology, but in rheumatoid arthritis, the rheumatologists or other rheumatologic conditions are very used to combining a lot of these drugs. So we just have to adapt to the times and catch up with everybody else and what they're doing. That was a whirlwind. So anyway, enough of progression. Let's talk about something else. What do we got?
We did have one question submitted online. My daughter was diagnosed through an MRI. She has no symptoms. Are there other tests that she should get to confirm that she has MS?
Great question. So traditionally, we've had the requirement that you needed to have symptoms in order to call it MS. We keep changing our criteria. So the 2023, which is when they met, they were expecting to get the data out by 2024. That's when they presented it to everybody, to the world. It hasn't come out yet. So maybe they'll call it the 2025 criteria. So we're not sure. Anyway, the newest criteria that are to be coming out, as we kind of see so far, actually includes the possibility that people on MRI could be diagnosed as MS. They just require a higher bar to kind of meet the criteria in order to do this. So what do I mean by that is you need to have lesions in multiple areas of the brain and the spinal cord or the spinal cord. You can kind of check off things. So it's helpful to do spine imaging if they've only done the brain MRI. Spinal fluid might be helpful in that situation. And I think it's a requirement for RIS definition. You can do eye scans because the eye optic nerve, which 20% of patients developed an optic neuritis as their diagnosing symptom, was never part of MS, but now it finally might get its rightful place as an area for MS. So as we keep adding layers to it, we're starting to kind of push that boundary to diagnose MS earlier so that we can treat earlier and hopefully prevent that disability accumulation. So I would say spinal fluid, maybe eye eval, so things like OCT, which is like an infrared. It's an ultrasound that uses infrared instead of sound to look at sort of damage to the nerve in the back of the eye, and spinal cord imaging would probably be the next things. And then a lot of repeat MRIs, because that's what we do, and see if things change and that kind of stuff. Cool. Should we talk about maybe measles a little bit? I mean, we're ground zero here. So for people that are not aware, measles is a thing again. Vaccinations have dropped off and those kinds of things. So measles has kind of popped up a little bit. The first confirmed cases happened in Pueblo, or were identified in Pueblo. So it's important to kind of recognize what measles is. I think most of us didn't grow up with measles or a thing. It was the kind of stuff they'll say like, we'll never see measles, forget about it for my test. As soon as I took my medical school test, and I'm having to kind of like relearn what measles is. So measles is a disease that for 4 days, you can end up with like a febrile illness, runny nose, cough, fever, that kind of stuff. At around 4 days, you can start developing a rash associated with it. End up with measles. You can be contagious for the 4 days before you have a rash, and about 4 days after the rash disappears. So it's good to be aware of not picking people's noses that have runny noses and that kind of stuff. One of the biggest issues for us in the MS space is that it's one of the few remaining vaccines that's a live attenuated vaccine, meaning the vaccine actually has live virus to it. It's attenuated, so it's not going to be very effective. And if you have a good immune system, you're going to attack it just fine, form a great immune response, be able to fight it later before it becomes an issue, and that's great. And it's usually given in kids, except if you miss the window, and now we put you on our immunosuppressive drugs, you don't have that immune system. So potentially the virus could start taking over and cause measles. So for a lot of our drugs, we don't recommend getting the measles vaccine. It's tricky because for things like B-cell depleting therapies, I've heard a lot of times of like, I'll just wait 6 months, you know, I get the drug every 6 months, my immune system will be normal. Good luck trying that. A lot of times B-cells don't come back for longer than 6 months. So you have to kind of make sure your immune system is actually kind of back to normal if you want to get the vaccine and things like this. You can check to see if you have the antibodies to the measles virus. So that's a way to kind of check if your vaccine as a kid did form a good response and you still have those. If you responded to and then started the drugs afterwards, that should be fine. One of the interesting pieces around this is that to fight the measles virus, when we talk about immune cells, there's many different parts to it. I think about it sort of like the military. You have the Army, you have the Navy, and this kind of stuff. Within the Army, you have tank units, you have artillery, all this other stuff. You might have, you know, heavy units and lighter units and, you know, helicopter units and all this other stuff, right? So the immune system is kind of the same way. And it can get complicated, but you have white blood cells. So we'll call them white blood cells. You can have 5 different types of cells under that. One of these are the cells that form those iron rings that are kind of the scavenger cells, those macrophages. But within that are lymphocytes. I'm just going to call them lymphs because they kind of like to live there. And then it becomes the alphabet soup if that wasn't enough, right? So this is where then you kind of split this into different groups and you have CD3s or T cells, CD20s or B cells, and NK or natural killer cells, and they have another CD number 52 on there. And then these you can split further into like CD4, CD8. This one should ring a bell from the HIV days. So a small chunk of cells can make a big impact. For measles, these don't seem to matter that much, and it's mostly these cells, those T cells that are important. So you should be able to mount a good response to the measles vaccine if you get the measles vaccine on some of these other drugs and don't have B cells. It's just, it's not recommended because the virus could take over. But what's important about that is if you don't have these cells because you're on B cell depleting therapies, or a lot of the other drugs still impair the function of these cells, you still have these cells. They should let you fight measles about the same as anybody else. So you'll still have a febrile illness, and all that kind of stuff, and the rashes. It might last longer because you may not fight it as well, things like this. So not to provide comfort about this stuff, but to kind of say, it shouldn't be as bad as maybe the pandemic where we had no experience with any of these cells having seen anything like it before and having harder issue to begin.
I've had MS now for over 20. I've had MS now for over 20 years, and I've only had one exacerbation years ago.
Yeah.
Does that mean I could clear it?
Yeah. So the number started to get a lot of wiggle lines. So let me remove this one because I got to draw a line going the wrong way for that. So the number of attacks as you get older actually goes like this. And I'm losing my pen. Let me try this one. Cool. Thanks. Appreciate it. So the number of attacks goes down. And what that means is that, it never goes to zero. So first of all, I think it never goes to zero because we keep saying that as disability levels go up, those pseudo relapses become a bit of an issue. And so there's always going to be a little bit of noise as we try to measure that. But around age of 60 becomes kind of a flat line. So that's always been a target about stopping drug and kind of saying like, okay, what does that look, what's that number? The problem is 60 is a bit of a tricky, if you just use that, it's a bit of a tricky number because I have patients and about 5% of MS patients get diagnosed after the age of 60. So it'd be hard to say, oh, you're 63, you just had a relapse, but because you're over 60, we're not going to treat you because you can't get a relapse after the age of 60 after we just diagnosed you. Anyway, you get the point, right? So the idea is you need to have some time of stability. If you have somebody who gets diagnosed at age 10, by the time they get to 60, they've had it for a really long time. So how stable, how long you've been stable, your age, all those are factors that we look at a little bit for that discussion around stopping disease. And then I would say it's not like it ever dies, it's just the probability of an attack goes down. So it's a little bit like Vegas, right? With our drugs, they got side effects. They cost money. You have to do labs. You have to put up with us in clinic and those kinds of things, right? And so you get to the point of saying, is the risk of those relapses higher or is the risk of the drug higher, right? And so what this tells us is that that balance is shifting all the time, right? It's never the same. As you get older, the risk of the disease goes down. The risk of drugs might go up because your immune system isn't as good. So you might get more pneumonias as people without MS would, or you might get more shingle risk or things like that. And so the effect of the drug is going to be a little bit worse as far as some of those risks kind of go. So because you're trying to balance all those things, right, you have to kind of look at everybody and kind of make a guesstimate and say, like, I think based on how stable you are and your age, we might consider stopping treatment. One of the things I've kind of been doing a lot recently is all the stopping trials basically use the old crappy drugs and lower efficacy drugs. And most of our patients now are on the high efficacy drugs. So we don't have a lot of experience in stopping those high efficacy drugs. And so the concern around that is, do you want to stop those, or maybe you take a step down and you kind of go to a medium tier drug, maybe to a lower tier drug, and you kind of do a gradual phase out of the drugs as opposed to just stopping it. So that's kind of what I've been favoring recently, and I've been doing some studies around. Did that answer your question a little bit?
I always like to shoot up every day, but he told me I could not do it. I haven't done it now for a couple of weeks, and I'm still feeling the same. So he told me I could slow down or stop it.
So one of the other things too is that most of these drugs take some time to take effect. Usually the number I use is at least 1 to 3 months. Some drugs might be closer to 6 months. And then when you stop drug, it's going to take the opposite time for the drug to actually wear out. So you know, when you have a drug that stays in your system for a long time, it's going to take a long time for it to wash out. Some of our MS drugs have some of the longest half-lives of anything I know. Gilenya has a half-life, I think, of like, I'm making this number up, but I don't think I'm too far off, of 50 some days. Do you remember? Okay, it's 50 some days. So that means that after 50 days, you still have half your levels of Gilenya. Obagi, actually, we looked at Obagi this morning, teriflunomide. The half-life is 20 days. So usually we think about needing 5 half days to get rid of drug or have the drug build up in your system. So you're looking at 100 days or 3 months just for the drug levels to get to where they are at, and then they have to do their thing to actually start working. So it's a lot more of a transition.
Do you have any experience with the Tau patch or Dow patch, TAO patch?
I think I've ever heard of it.
Um,
Always learning.
Yes, yes. And then another question, can you comment on any ongoing MS studies with plasmalogens?
With what, sorry?
Plasmalogens? Plasmalogens?
I don't.
Okay.
Is that somebody from here? No. Sorry.
Yeah, I'm not sure. What about fatigue? Let's talk about fatigue.
Let's talk about fatigue. All right. If they're not fatigued enough yet of listening to me, so fatigue is the #1 symptom in MS. I think it's probably the #1 symptom in people without any disease. And the problem with MS fatigue a little bit is that it's a non-specific symptom from MS. So meaning if you have cancer, if you're pregnant, if you have any other disease, fatigue is part of that disease usually as well. When you're evaluating for fatigue, it's important to recognize that in MS, there is a biologic reason a lot of times for that to be the case. It's not people just complaining of fatigue because they don't want to do stuff or it's hard to do stuff or things like this. So I think it's important just to put it out there, right? So the way the nerves work is you got to get a signal from point A to point B. And if you can send those signals well, awesome. If it takes a lot of energy to send that signal, it doesn't work very well, right? So we have things like myelin, which is insulation around the nerves that makes that more efficient. For electric wires, if you use high voltage lines, it's much more efficient to send electricity. So you lose a lot less energy than if you're sending it through lower voltage lines, where then you're much more likely to lose power as you go through. If you don't have that insulation of nerves, it's possible that that signal just peters out and doesn't get through. When you look at the nerves, we'll draw here. So this is the nerve, and you got myelin sitting here. And let's say the electricity usually will jump from node to node instead of having to kind of go through here. So it's a much more efficient, and that's why that insulation helps get the signal through it. What we see is that there's the powerhouses, these mitochondria that produce energy, that tend to concentrate here because they can change the voltages around these areas to make it more efficient so that they can make this jump. The problem is when you lose that insulation is you can't jump. And so these powerhouses, you need a lot more of them to kind of change this whole area and treat it like that small area. So you're using a lot more energy to kind of get that signal through. So that's one mechanism by which this becomes an issue. To use word finding as an example, you know, if you ever kind of like, oh, there's that one word and you can't quite think about it, right? And sometimes you can get the point across by using other words. but it's maybe not so efficient, right? You have to use a sentence as opposed to a word to kind of get it through, right? So that's a little bit what happens then if this nerve dies. And instead of being able to send a signal using a straight pathway, you might need to go to C before you can get to B. So now you have a longer stretch pathway to kind of do it. So that's another mechanism where you can kind of take more energy to do stuff. So it's typical sometimes for some MS patients, they'll come in and we do an exam at the bedside, and it's like their strength is full, you know, they're strong. And then you're like, so how far can you walk? And they're like, 3 blocks. And you're like, wait, what? Like, why? Like, what happened? It's like, it's just, that's how fast they peter out. And so they're using so much energy that instead of being able to get, you know, and do several miles and make up the energy as they're using it, they just peter out that much faster. So fatigue could be an underlying MS issue, or it could be so many other things, right? So when you come to fatigue and we start asking you, what about sleep? You know, it's like, oh, I sleep all the time. Oh, but do you snore? You know, because maybe you have sleep apnea and you're sleeping, but your sleep, instead of getting into the deep stages of sleep, is not happening. And you're actually kind of constantly sort of like waking up to 100 times an hour sometimes if you have bad sleep apnea. So that's never going to be a good restful night, right? And then you're sleepy. So we got to treat the sleep apnea. Or you find out that, for example, bladder stuff is so bad that somebody's waking up 5 times a night to go pee. Good luck trying to get into those deep stages if you're constantly having to get that up, you know, get up that often. And that could be MS because of bladder damage from the MS, or it could be prostate issues, or it could be a number of other things. So we got to fix that. And I can go through so many more examples of that. So that's why we ask so many questions around fatigue, and it becomes so important to kind of really try and figure out like what's causing the issues. Once we can kind of say, hey, I don't think it's because of bladder stuff. I don't think you have sleep apnea. You're sleeping a good number of hours, because sometimes the answer for fatigue is to actually give you sleeping meds, you know, so you actually sleep at night and those kinds of things. Then it might be, hey, what can we do to kind of give you some more energy? There's a few drugs that we like for this. We use sometimes amantadine, which actually has a trial for fatigue and MS, and it works. It's an old flu medicine. Doesn't do anything to flu much now anymore. It's all pretty resistant to it. We use it for Parkinson's disease for, I'm not sure if you've seen like Michael J. Fox or some of the patients, not so much with the tremor, but where their movements just kind of get really crazy a little bit more so. It helps when they're on too much of the dopamine drugs that they use. It can help with that. We can then use Provigil, modafinil, Nuvigil are kind of the generic and brand names for a couple of similar drugs that we can kind of use. We can use stimulants. We prefer sometimes not to. It's hard for us to prescribe them, but you know, if there's a primary care provider that's willing to prescribe them or something like this, that they can be pretty helpful. Because of the rules, they have to be prescribed every month, and they can only be given for 30 days. And it requires a wet signature, or you know, like a harder, you know, much more. The prescriptions are harder to put in other words. And so it's just one of those things that we try not to see you that often. You don't want to put up with us that often. A lot of you guys travel a long distance to see us. You know, it's much easier to have, you know, a doc that's local, and you have better access to kind of manage those meds a little bit. So just it becomes a little bit of the hassle of the system has become so bad that it's hard for us to prescribe them. But that's another way then that you kind of can kind of look at sort of managing that.
Switching over to some medication-specific questions.
Yeah.
Can you talk about the risk of PML with Ocrevus or all of our drugs in general?
Yeah, I really know what PML is. Maybe start with a review. So PML, we call it PML because the real name is too long and it's like a tongue twister. Progressive multifocal leukoencephalopathy. So this is a virus. Pretty much we all have it. It lives in our bladder, hangs out there. It doesn't cause a urinary tract infection. It's just happy. It doesn't give us symptoms. It doesn't give us problems. But if you get some specific mutations to it, instead of attacking the bladder, it can start attacking nerve cells, and it can go to the brain. And so in our immune system, if we're kind of protecting the brain from the immune system, as we want from MS, it might provide a place where then this virus can kind of as it mutates and multiplies, it can kind of go to the brain. And so it can cause an infection of the brain that can be pretty much lethal. In the old days, it was lethal. We wouldn't recognize it until very late. Now, if we can kind of reverse the drugs and things like this, sometimes we can make people survive it. How well they survive it, all this kind of stuff is always a little bit tricky. You will hear about the JCV testing, the JC virus, not Jesus Christ, but just John Cunningham. That was the person they isolated the virus from. The virus, it doesn't measure the virus, but it measures antibodies to the virus. We think for some diseases, if that number is higher, not for some diseases, we think that the risk for developing the disease, this infection, is higher if that number is higher, because it probably indicates that the virus is just more active in those people. In some people, the immune system probably keeps it under check and it's not a big deal. We worry about this a lot with natalizumab or Tysabri. This is an infusion that we use quite a bit, especially in the 2010s. They got approved in 2006. Because of this infection, it got withdrawn from the market in 2004, withdrawn in 2005, came back in 2006. It works really well. It's a short infusion, pretty well tolerated medicine, but about half the people are at high risk for developing PML. If you have a positive antibody test, that risk with that medicine at normal rates of infusions can be as high as up to 1 in 90. So pretty real numbers. If you're negative or low, it can be as low as like 1 in 10,000. So that kind of provides a bit of a perspective. Chances of getting hit by lightning is like in the hundreds, things like this. I made that comment. It's like, oh, it's unlikely. And then they were like, I got hit by lightning twice. So true story. So, I mean, it happens, right? I think, so for Tysabri, it's a helpful test because those numbers, if you're positive, can be pretty high. The other thing that goes into is like, how long were you on treatment? So that makes it higher. Usually we don't see it within a couple of years. And if you had chemo, that can make the numbers higher. We've not used chemo for MS a lot in the US. It's much more of a European thing. So they tend to have higher rates of PML with Tysabri. With other drugs, we can see it. So on B-cell depleting therapies, I lost track of the latest numbers, but I think it's like 3 cases with Ocrevus. There were like low teens with Tysabri, with Tecfidera. On Tecfidera, the lymphocyte counts, so these cells, if they got below a certain number of 0.5 or 500, depending on how you measure them, the risk goes up. So for some of the drugs, there's different marker numbers that we kind of use to kind of determine the risk. But the risk that you start to look at for most of these drugs is 1 in 100,000. So there's been probably about 500,000 people on Ocrevus. So if you got 3 out of 500,000, not bad. The risk of a lot of other things is much higher. So it's putting it in context a little bit, and kind of things to kind of worry about. There's only the old injectable drugs don't have any risk of that, but there's always a bit of a risk from other conditions. And so we could see that a little bit sometimes in cancer patients, HIV patients, we saw a lot of it. That's kind of where we started to really see this disease and things like that. So it's good to have that number as a perspective. Gilenya, the numbers got kind of big, and I think that's where you saw a fall off. And by kind of big, I mean like 1 in 10,000, 1 in 6,000 were kind of what the numbers were headed after being on drug for a long time. So that kind of alternated that a little. So again, on B-cell depleting therapies, even if you're JC positive, the risk of PML is pretty damn low because half of our patients on B-cell depleting therapies are JCV positive. We check them sometimes we don't, because it doesn't push us in one direction or the other. So that's a little bit about PML. We don't have great treatments. The main thing is just to try and reverse the immune system. There's been a lot of stuff that's been tried for it, but it works in in the lab, but it hasn't really worked out in patients.
Can you give your thoughts on Ampyra? This person has a prescription, but they're worried that it's expensive and has a lot of side effects.
Awesome. I love Ampyra. So Ampyra, dalfampridine, was a very expensive drug. It's gotten a lot cheaper as it's become generic. When we talk about fatigue, Ampyra makes this more efficient. It actually kind of works like the energy factories a little bit for that stuff. So it helps signals make it through these areas that don't have that insulation for it. So that's how the drug works. So it doesn't work for everybody because some people just don't have the nerves to begin with. But if you have the nerves and they're missing the myelin, then that can work. Usually it's about a third of patients that I kind of expect the drug to potentially work on. And the only way to test it is to see if it works. Yeah.
I have one night where I didn't take it early enough. Well, I actually took it, was supposed to take it at a scheduled time, but I took it a little earlier that night. And I think my girlfriend called, something threw me off. And I went to go outside to shovel the walks, and I was like a different person. I told my husband, that's when I told my doctor, I see Dr. Jeffrey Bennett, and I told him that's when I realized how much it helped.
Yeah.
So you kind of have to deal with fatigue, but I feel like the benefits of it is wonderful.
Yeah, it just gives you a lot of times the stamina. So what does that mean? It depends on the person. It might be more balance. It could be a little bit more strength. It could be a little bit less pain and those kinds of things. We probably wait a little bit too long to start the medicine. We tend to think about it. Our cue in clinic a lot of times when we see somebody with a cane or something like this, it's probably better used when you're kind of in that, I'm not walking normal, I'm petering out before my normal distances, you know, not quite to the cane stage, although with those patients, it can still be helpful. The biggest side effect with that is whenever nerves work better is of seizure. So this drug is an extended release version of a really old drug that people used to have to take every 2 hours. Yeah, right. And so you forget if you had taken it or not, or this kind of stuff. And it was common for people to take the medicine a little bit too close together, kind of stack the doses, kind of get levels that were really high. And then that's where we saw a lot of risk. With the extended release, we see less of it. It's about a 0.5% risk. If you do have a seizure or have had a seizure in the past, the drug really shouldn't be tried. And so it's the one thing to kind of worry about. This is one of those drugs that we say this is an every 12-hour drug. You can shorten it up a little bit. It doesn't have to be exactly at 12 hours. But if you miss a dose, you kind of want to skip it and go on to the next one. You don't want those levels to get kind of high. As far as the expense, there's still sometimes a patient assistance program. Honestly, what we have started to do, so when it was still expensive, we could compound it. So there's some certain pharmacies that would take the old drug and just make an extended release product out of it. What we're doing now a lot is going through Mark Cuban pharmacy. So Mark Cuban of like the Dallas Mavericks, Dell Computers, Shark Tank, all that kind of stuff has a pharmacy that makes generics. And they sell it, I think it's like $20 a month with no insurance is the only problem. But for $20 a month, it's often less than the copays for most of the drugs that we have. And so it's made it reasonable and accessible for most patients. And a lot of the hurdles that we used to have to jump has gotten a little bit more realistic for it. You can get a little bit foggy in the head when you first start it. So sometimes I do recommend it. And I do have people that just take it once a day. You know, older patients, smaller patients, that kind of stuff. So you have to kind of tailor it a little bit, but most everybody takes it as a twice-a-day drug.
I was recently reading about two therapies that may show some benefit for MS. The first one is hyperbaric oxygen therapy. So I'm wondering what would be the mechanism where that might benefit. The second therapy was high dosages of vitamin D3. And, you know, what would be the optimal dosages or blood levels for D3?
Yeah. All right, the one I know less about is the hyperbaric oxygen. At least you mentioned some that I have some familiarity with, as opposed to some of the prior questions. So this I can make some stuff up on at least. So hyperbaric oxygen, the idea is that it helps flush out, some of the stuff that builds up when you exercise. And I think to some extent because of the fatigue issues, the idea in MS patients is it might help kind of regenerate muscle kind of strength and energy levels and stuff like that to make things better. I don't know that it's necessarily a muscle disease. At least I don't think it's a hurtful therapy. So I think it's something that, sometimes if you have access to it and you have the means, it might be worth trying and kind of seeing what your effects are. For a lot of alternative therapies, I think one of the biggest things to think about is how hurtful is it versus how safe they are. And if it's not hurtful, how much does it cost, or maybe hurtful to the pocketbook, then it might be worthwhile, trying it. And if you find it helpful, then that's great. I would put hyperbaric oxygen into that category. Vitamin D is a tricky one because there's regular vitamin D and then there's these mega doses under the Coimbra protocol that might be what you're referring to, which are really high doses. So vitamin D, just to kind of talk about that a little bit, is a vitamin that, nowadays we say you don't really need vitamins because you tend to eat them all if you eat healthy and all this other stuff. Vitamin D you tend to make from sunlight. So we tell you guys to wear sunscreen, and most of us choose to wear clothes when we go outside. And especially in the winter months, it's just probably too damn cold not to. So we don't tend to get a lot from sun as much as we used to when we lived closer to the equator and temperatures were milder and we didn't wear a lot of clothes. The other piece to this is the one food source that we can get a lot of vitamin D from is liver. Yeah, I'm getting a lot of no's. That's pretty much what I get in clinic as well. The one time I had somebody say, yes, I do eat liver, I was like, when was the last time you had it? And it was like 2 years ago. And it was just like, I don't think you like it that much. So what does it do? So why did it become a big thing? So the observation is that people with lower levels of vitamin D tended to have less attacks. And where you tended to see a lot of MS was the farther away you got from the equator, where there's less sun exposure, and so there was less vitamin D levels. So Nordic countries, and you can actually see these gradients. In the US, northern states have more MS than sort of southern states. In Australia, it's the opposite. So the southern states have more MS than the northern states. And those kinds of things. There was a trial with one of the interferons. I want to say it was beta seron, but it might have been Rebif, in sort of patients who had had one attack, and they were looking to see if at that point, you needed to have 2 clinical events to get called MS. So they went from CIS, or clinic isolated event, to MS, and they had blood stored from that. The drug worked in preventing the formation of MS, so it reduced relapses, but from that blood level, they were able to see that the people who went on to have MS tended, to develop that second attack, had lower levels of vitamin D. And the effect of vitamin D was almost as good as the interferon levels, like treatment with interferon. So it looked pretty promising. I think we still do it a little bit because of the natural issue with vitamin D. Most people tend to be low. At low levels, to have fatigue is common with vitamin D. Vitamin D lets you absorb calcium, which you need for a lot of those enzymes in your body to work well, but also healthy bones and that kind of stuff. It lets you absorb calcium. And so in the past, when we used steroids, which thinned out bones a lot, we're thinning out bones, your vitamin D is low. So to have thin bones, people, if they had a lot of disability, weren't exercising, you need weight-bearing exercise to build strong, healthy bones. So all these things were strikes against our MS patients. We pushed it a lot. With our drugs now, the effect is so good on relapses that it's hard to pick up a signal for vitamin D. If you use kind of lower efficacy drugs, they might still add something to it. But I think from a health perspective, it's important. Now, a normal level, according to the Endocrine Society, is a level of at least 30. If you look at UC Health's reference range, it goes down to 13, because they only look at what people are, not what they should be as their reference range. And in the state of Colorado, through the patients that come through UC Health, that is the lower end of the 95th percentile. So most patients are less than 30. So just to kind of provide a perspective as to how common it is. Now, at the upper end, we don't have a well-defined upper end. According to the Endocrine Society, it was 80. They're kind of lowering a little bit, because what happens at the high levels is you can start to thin out bones again, because now you start to pee out calcium. You don't need it, so the body's trying to get rid of it. And so with the Coimbra protocol, which is a Brazilian doc that used to treat MS for the stars, started to do doses. Like I might recommend 2,000 to 5,000 units a day of vitamin D. The prescription strength vitamin D is 50,000 units a week. If you're doing 5,000 a day times 7, it's 35,000. So the prescription doses were there from a long time ago, because the over-the-counter stuff is just that much stronger as it is. The Coimbra protocol was something like 50 to like 80,000 units a day of vitamin D. We can measure through the university up to 150. I've seen some patients that were on this protocol that I couldn't even measure, because our lab wouldn't measure that high. And I've seen urine that was so thick with calcium that it was almost like a slurry. So I'm nervous about those really high doses. There's some protocols now that are being developed where they reduce how much calcium you have in your food, so that you don't then dump it out in your urine and lead to like kidney stones and things like this. That might be better for it. But again, from an MS perspective, for relapses, which is where this has been sort of developed, we have such good drugs that I don't know that you need to worry about it. So I get a lot of vitamin D questions, so that's why I wanted to kind of go through detail on it a little bit.
We have a couple of questions about diet, looking for updates on studies looking at diet and the effect on MS. What's the best diet plan for MS? And then also, if you could talk about just in general, what are the lifestyle strategies that you've seen have the most impact on MS symptoms?
Okay, I'll try and remember all that. From a diet perspective, you'll see all kinds of stuff and all kinds of advice on the internet. I'm a simple guy, so I try to keep it simple, and I say a healthy diet. That depends on people, right? If you're allergic to tomatoes, don't eat tomatoes. And so you'll see some diets that really cut out a lot of stuff, including a lot of stuff, almost everything. But you'll see a lot of diets that cut out dairy, that cut out gluten, and those kinds of things. I think if your body processes that stuff, it's okay, everything in moderation. If you do okay with dairy, I think it's fine to have dairy. I think you want to do, usually what I tend to recommend is that if it's good for the heart, it's good for the brain, and there's a lot more research in that arena. So a Mediterranean diet, kind of low salt, maybe low salt, and sort of few refined foods, more fruits and vegetables, those kinds of things are probably, is what I recommend. I think if you do all those things and you feel better, awesome. Like, keep doing it. I think it's great. No problems with trying to be restrictive, as long as you're making sure you get all your nutrients and things like this that you need to do with that, or supplements. But what I tend to see a little bit is people get diagnosed, they go sort of, crazy on their diet, and, now they're starting to eat like, taking hours to prepare their meals, and, this kind of stuff. And every time they look at a plate of food, now it's a reminder about their MS. And I think you need to get away from that. Like you have, like, it's a good time to make change, but you have to do it realistically and kind of do something that fits your lifestyle to some extent. So just being aware of that, I think, and trying to find a good balance is important. Lifestyle stuff, though, all the other stuff that you're going to hear from any other doctor still applies to MS patients, right? So we're going to try and kind of holistically look at all these different things becomes important, right? Like you want to be a good weight, because if you're overweight and you have weak legs, it's just not going to let you get around, right? It just makes it that much harder to do things. The fatigue issues become that much more. You're more prone for diabetes, for sleep apnea, all these other things. I unfortunately have patients with MS who've had stroke, so you want to reduce the risk of other things that might kind of pop up as well, and things like this, and just kind of try to find, that a good balance with that stuff. So exercise is the other balance to this stuff. It helps you build up strength, that kind of stuff. And then the other question that people ask me is, what's the right exercise? Should I do cardio? Should I do weights? What should I do? Again, I'm a simple guy. Like, do whatever you like. Like the idea is you need to do things that you will do. I think my problem a little bit, my wife was a swimmer in high school. I'm a floater, maybe. I mean, like, I don't mind hanging out with the kids in the pool, right? But swimming laps, like halfway through the first one, I'm falling asleep in the water, So I like activities where it's group play, so ultimate frisbee, I like to play soccer, haven't played basketball, but those kinds of things are the things that I'm much more likely to kind of get me excited. Somebody's chasing me, I'm chasing somebody else, you're having a beer afterwards, like, whatever it is, right? But you enjoy those things. So, my son likes the mental challenge of climbing. So like, planning the route as he's looking at the wall. I'm afraid of heights. So again, not good for me, awesome for him. Those kinds of things. So I think finding what you like to do becomes just, the part to it that I think is so important.
So speaking of weight loss, what do you recommend for overweight?
Yeah, so I think sometimes it's evaluating sort of what you're doing and where you're at this point, right? I think, I mean, I recognize I could lose some weight too, and so there are certain things that, that I've tried to do. And I think you try to evaluate sort of how you eat. I'm a terrible snacker. Middle of the night for me to go grab, a couple of cookies and it might become 4 or 5, and a couple of glasses of milk, is not uncommon. So I try to make sure that, I don't do that as much during the middle of the day, especially on my clinic days and I'm just busy. It's, I try to, I might snack. So I try to do maybe, hey, maybe I like that food and it helps me go, but I'm going to try and do maybe fruit as opposed to trying to do, something else. What is that fruit? Bananas, maybe not so good. I'll try and do some other things.
Weight loss drugs.
Yeah. So I think it's a little bit of kind of, if you've tried all the other things and then you're starting to kind of look at drugs, then you have to kind of talk to your primary care doc or talk to, somebody that specializes in those things, because there's certain, I forget the name of the drug, the older drugs, that phentermine and those kinds of drugs, right? If you have heart issues, high blood pressure, those kinds of things, those are not the right drugs for you. What I would say is all the new drugs, the Ozempics and all this other stuff, right? We've seen people do great with them. They do have some issues with them. If you have a lot of constipation from MS and you get constipated from those drugs, it can really back you up. So you have to kind of, be under the guidance of somebody that can kind of walk you through them and kind of see the benefits of them and those kinds of things. There's none of these drugs really have an effect or interact much with our drugs. So they're pretty clean from those, from that effect. The biggest thing right now is just the cost of them. They're just so expensive for them to do. Yeah, and then it's combining them with all the other stuff. Yeah.
We did have 2 different questions on biomarkers and kind of the personalized medicine. One question was specifically asking about the Octave test. Do you use it, and what might how might a physician use it? And then also, if they're not being offered these personal biomarker tests, how do you go about asking for them? And what if they don't know how to interpret the results?
All right, I'll try to remember all this stuff too. So personalized medicine is what we try to do for everybody. I mean, sometimes more successfully than others. And I think, you know, if they're not being offered, you should always ask. So I mean, just kind of blatantly saying it, like you should ask and see, you know, what the thoughts are from the providers. I like to think of myself as a little bit as a biomarker guy. I have papers looking at different biomarkers on neurofilament light, CXCL13, all the alphabet soup, you know, stuff related to some of these things. But I struggle with the way that we practice on how to use biomarkers in our practice. Okay. Now, what is a biomarker? We tend to think about them as sort of some protein you measure in blood or spinal fluid or this other stuff. But just to kind of take a step back, a biomarker is just a biological marker. So I mentioned our most common biomarker, and I use it all the freaking time. Age, right? Number of attacks go down with age. Men tend to have worse disease than women. MRI stuff, right? We talk about clinical symptoms. I get an MRI, I see if there's new lesions, right? That to me, new lesions, contrast enhancing lesions, those things, those are the biomarkers I know how to use and interpret, and that's why I use them. Neurofilament light, which is probably our most common one, that's kind of the furthest along in this stuff. When you look at hundreds of people in a clinical trial, it looks awesome. People who have the MRI activity, their levels are high. The more lesions you have, the higher the levels are. If you go into a trial and the levels are high, the worse you're going to do in the trial because, again, you just had more damage to your nerves. So it makes sense that that's going to be the case. I think the problem is in the details at the individual level. So as you get older, levels go up for NFL. As you're bigger, the levels go down because brains tend to be about the same size. And if you're twice the weight of somebody else, you have twice as much blood, so you're going to dilute it out. And so you'll have half the level of somebody who's tiny. So you need to adjust for those things. And even Mayo only adjusts for age at this point. Doesn't adjust for BMI, weight, or any of this kind of stuff. There's a website that you can go through in Europe that will adjust for all these things, and it gives you a score. And so, but then the question becomes is with an attack, how long does it take for the levels to go up? Probably not as fast as I would think it would. So this has been looked at in stroke, right after stroke. And I use stroke as a good example because usually we know when the symptoms start. You know, sometimes it happens in sleep, maybe not so much. But if it happens during the day, your arm goes weak, you kind of say, oh, that was when it started. You know, and then they looked at NFL at an hour, 2 hours, 4 hours, 8 hours, you know, this kind of stuff. And it takes 10 hours. No, just kidding, 10 minutes. All right, sounds good. So, and then you'll see that the levels don't go up for sometimes 12 or 24 hours. So you may not pick it up things really early. On the back end, when you look at clinical trials, even at 2 years, the levels of NFL at the population level are still going down. At the individual level, they're much more responsive, but there's very little data at sort of what happens at the individual level. Now, when you talk to people from companies and things like this, they will tell you, well, there was that one case, you know, where we found that patient, that the levels went up and went down, and we could detect that there was some disease activity. It's like, I did too. I got an MRI and it showed me that disease activity. To detect a lesion, a relapse with NFL, you probably need to draw it every 3 months. We can barely get you guys in every 6 months, you know, that kind of stuff. So trying to do something every 3 months is just not going to work very well. And we're still going to do the MRIs. So I don't know that it's very responsive. I don't know that it replaces the information that I get from an MRI. It doesn't tell me how much damage it caused, where the lesion is, those kinds of things. So I've not used it in practice much. We did a study that switched people from rituximab to Ocrevus, and the only people that had low levels were all the small people. That's what I was able to predict out of that study. And if you're using it in people with really good drugs where there's no disease activity, the levels just don't change. Octave, about half the value that you get from their value is NFL. And octave, meaning 8, there's like 7 other proteins that go into that stuff that play less of a role. To me, play less of a role in sort of trying to figure this stuff out. So it's good if you're maybe on a lower efficacy drug and you're at high risk and you're trying to kind of monitor it, you can't get access to MRIs. But at one point, the octave test was about $1,000, so it was more expensive than the MRI. It's down to $100 again, so maybe it's reasonable. But I get so much more information from an MRI than I do from the testing that it makes it a little bit hard. So I think you have to kind of put all these things together, and I think we still need a little bit more data to kind of learn what we can learn from these biomarkers.
Does a high ferritin lab indicate a possible flare or progression?
Not that I know of. So ferritin is a marker of inflammation sometimes. It could also be a marker of anemia or iron deficiency. But usually blood markers of inflammation like CRP, ESRs, and things like this haven't matched up with MS inflammation.
Same person. I'm experiencing a lot of new symptoms lately, but they're not meeting the 24-hour requirement to suggest a flare. Does that mean that I may be progressing, or is it simply symptoms from silent lesions?
Not silent if you're getting symptoms. So this is the tricky part, right? So, but is it a pseudo thing versus a real thing? That's where you need data around sort of the MRI stuff and getting those MRIs to kind of evaluate it. Sometimes it's a little bit easier to evaluate it after you've had this for a while and some stable MRIs, and you say, hey, when I get overheated, my right leg goes weak or things like this, then you know that's probably sort of not new lesions. At the beginning, we do more MRIs because you're trying to kind of match up those symptoms to what the MRI is helping us with, and those kinds of things. So you need to discuss that, I think, with your doc a little bit more to kind of see. But if it's the same symptoms, we worry about pseudo relapses as well. I would also say at the beginning, if you've not evaluated for that, it does probably require a conversation with your doc and not blowing it off.
I keep experiencing a really weird sensation in my head, mostly when driving. It's almost like a sort of tunnel vision happens and my consciousness takes a back seat. It's hard to concentrate and feel my senses around me. Is this normal? Is this related to MS?
Not normal. Have a hard time tying it to MS. Because of the consciousness, you should not be driving for everybody else's sake. You know, but it could be just getting lightheaded, like orthostatic. It could be, you know, if there's some concern for room spinning components, that could be a host of other things. That may or may not be MS. So depending on some of the symptoms, just to kind of see a little bit more so about some of these things. There was a quick question that I wanted to kind of get at, which was the first one that you put in here. What's the role of the neuroimmunologist for someone with MS, and how can they help us? So part of it is doing this kind of stuff. But I would say, you know, part of it is answering these questions, trying to answer what things are, guiding you through making treatment decisions. There's a lot of stuff, not just about sort of, you know, the disease modifying therapies, but symptom therapies that the neuroimmunologist should be helping you with. Sometimes it's not drugs, but it's adaptive equipment, you know, so not forgetting about sort of AFOs or some of the stimulators for nerves and muscles that can sometimes help with a gait and those kinds of things. So, you know, referring you to people that know more. So maybe sending you to a urologist or getting you to, you know, a rehab doc or a PT person or urologist for urinary stuff or those kinds of things, or a primary care doc, because, you know, it might be outside my realm and kidney issues or things like that. So that's the rule for the neuroimmunologist.
This might help out with the question that you couldn't answer with that Teo patch.
Yeah.
I think it's just a newer technology of, say, like a Salon Pause or, you know, Icy Hot. I don't have MS. My wife does, but I'm a sports guy and I sometimes think I'm younger than I am. So we've been using sports cream or Icy Hot on some of her flare-ups.
Yeah.
So that's just a newer technology. Is that hurting?
It shouldn't hurt. Icy
an
hot would not
activation?
hurt any of this stuff. So
Okay.
one of the things a little bit, because I use Icy Hot for my low back stuff when I get spasms as well. And I see this a lot. Low back spasms are super common in MS. Sometimes, you know, especially with weekend warrior type stuff, a little bit is that the back doesn't exercise when you normally exercise. So if you're standing there doing dishes or other things like this, your back is making sure that you don't flop over. And especially if you're bending over a counter or doing things like this, I wouldn't call that exercise. But my back was working out for 2 hours if I prep food for a couple of hours, right? So it's a different muscle. It's a little bit harder to think about it in that sense. If you're walking straight up, right, then you're balanced on bone and the muscle doesn't actually have to do that much, but that leaning forward piece. So even if you're sitting, reclining, not much, all of a sudden, if you lean forward and you're not pressing your arms down, your back is all of a sudden working 100%. So it's super common to overdo it in the low back and get low back spasms. Super painful, can kind of mimic an MS hug. Those tend to wrap around a little bit more so. But if icy hot, massage, heat, cold, ibuprofen, all that stuff helps, it's probably more musculoskeletal. Rest, stretching, all those things will tend to help that a lot. And then slowly, very slowly try to build that up and try to kind of recognize when you're using those muscles to kind of try to break up when you're exercising them to kind of help with that stuff.
I have problems with lower back pain too, but there's 3 exercises I've learned that seem to be helping. One is lying on my back and then raise the legs up. It strengthens the back and the stomach.
Yeah.
And I do about 7 repetitions and I can see the pain level coming down.
Yeah. You can do it on your
Another-
side as well and kind of do
Yeah,
leg lifts.
another
That helps as
exercise
well.
is like cross my legs over and shoulder back, you know, both sides.
Really
That
stretching them
stretches
that
the
way.
muscles back there.
Yeah.
That helps. And then the third one, actually 2 variations of it, is lying on your stomach and get up on your elbows and arch your back as much as you can. And then try to raise up all the way with your back arched, and a few repetitions of those, and I noticed the pain levels coming down.
Yeah. The other thing I would mention is core. A lot of times we pound core and then people think core and they start doing sit-ups. That works great for the front of the core, but won't do much for the back. Those are much better exercises for the back muscles.
Final question. For years of sleep challenges, which are unrelated to sleep apnea, bladder challenges, pain, or spasticity, what are medications that you would recommend considering for sleep?
Yeah, so I like old depression meds a lot. So amitriptyline, trazodone are kind of my first line go-to meds for that. They tend to help reduce headache frequency. Sometimes you use them for pain. Sometimes it seems like they do a little bit of what ails you, and I think primarily because they help with sleep. If that doesn't help, then I tend to go to kind of the more kind of like benzo type drugs. So Ambien, Lunesta, some of those drugs. I try not to go there, but sometimes you know, it just needs those kind of meds.
Awesome. Thank you. That is all that we have time for tonight. Thank you everyone for joining us. Thanks for the many great questions. We will post a link for our evaluation form, and everyone in person has the form with them as well. Please do fill those out. I look at those. They shape our education programming for the year. And then I just wanted to mention a couple of other resources. We have some previous presentations on PIRA, that progression independent of relapse activity, which you can find on our website. We have a couple of issues of our magazine that might be interesting. One is called Food for Thought, and it discusses the role of diet in MS. And then our latest issue is called Caring for Your Brain, and that discusses all lifestyle things for brain health. And then just wanted to do one more plug for our education summit coming up on April 26th. We are having particularly, it sounds like the presentation on evaluating risk and benefits with medications will be interesting, as well as those research updates. So thank you again and have a great night.